Good afternoon, and thank you for joining us today on my podcast called The Bipolar Guy. I am the Bipolar Guy, and as I've said before, the reason that my nickname became the Bipolar Guy is because over half our practice is working with bipolar disorder. But also in our practice at Center for Integrated Therapies in Sarasota and the Palm Beach Gardens, and hopefully soon in the St. Croix U.S. Virgin Islands, we work with all types of clients. We work with bipolar, PTSD, anxiety, autism, migraines, sleep disorders, ADD, ADHD, traumatic brain injuries, and on. Anything really between the ears we focus on. But I would say the largest part of our practice is probably half of our practice is bipolar, and then the next one after that, probably about 35%, is post-traumatic stress disorder, otherwise known as PTSD. There's also a close sister to PTSD, which is ASD, which is acute stress disorder. In the DSM-5, the diagnosis handbook, acute stress disorder is up to 6 months. So somebody has a severe trauma of any type and they have all the symptomology of PTSD, but it wanes after about 6 months due to therapy or medication management or whatever worked in that case, and then that would have just been ASD. But once we get past 6 months and these continued symptoms persist or become worse, then the diagnosis would switch to PTSD. We're going to talk a lot about PTSD and its ramifications today, as far as relationships, as far as substance abuse, as far as how we get along and how we're treated, the invalidation that comes along with PTSD, having been traumatized, how trauma affects us as a child, how trauma affects us as we grow older, how trauma affects our brain, and why we have the symptoms that we do if we have post-traumatic stress disorder. We're going to also talk about medications, what med management does, and we're also going to talk about any type of trauma. We're going to talk about physical abuse, sexual abuse, emotional abuse. We might even touch a little bit about how today's internet and social media and bullying in the schools and bullying elsewhere, it doesn't just have to be in schools, and also how people self-medicate, marijuana, alcohol, and benzodiazepines is generally the course that they go. So let's just dive right in. And again, welcome. Today we're going to talk about PTSD here at the Bipolar Guy. Interestingly enough, most people that have bipolar present also with PTSD. They don't have to, but they often do. I'd say it's more than 50-60% of the time. So we can be traumatized many ways. The classic trauma that most people talk about or consider when they think about PTSD is a veteran coming home from war. And of course, that is a severe trauma. They have gone through some very traumatic things that people should never have to endure or see. But there's also very simple traumas. How trauma affects us and what our symptomology becomes is really dependent upon our environment and the resilience of our brain. There are people that can go to war and see untold things, horrible things, and come back without the symptomology of PTSD. And there are people that just go and have very slight incidents and still have the symptomology of PTSD. One example would be that 5-year-old or 6-year-old child who's riding his big wheel down the sidewalk or his tricycle, and a couple other neighborhood kids come over and bully him or her and push him off the bike. And the child's on the ground crying and looks up and sees his father in the doorway, not helping him or her. And when that child runs to the parent says, "Get back out there and quit acting like a baby," invalidates that child. That can turn into trauma, especially as once we get traumatized, oftentimes there's more traumas that follow once we actually have PTSD. So it could be what some might call that minor. It's not minor to that brain. And of course, all the way up to the sexual abuses, the physical abuses, emotional abuses in the family, emotional abuses and physical abuses in relationships, and so on. So what happens is when we're traumatized, whether it's in utero, whether it's a year old, 10 years old, 20 years, doesn't matter the age, but when we're traumatized, the brain is affected deeply. And it's affected in the amygdala and hippocampus. The research shows that the hippocampus actually shrinks and doesn't unshrink, doesn't continue to develop if it's a minor, or come back to its normal state if it is an adult. And so what that does for us is create that hyperreactivity and hypervigilance, as well as the other symptoms that we'll get into. So I call it the squirrel brain. Somebody's traumatized at 6 years old, And at 40 years old or 30 years old, when they act out, when they are reactive to a trigger, they generally act like a 6-year-old. So we can actually see or hear that that person's probably initial age by how they behave or how they act out when they're triggered again. And by that I mean something happens years later that's not related to the initial trauma or ensuing traumas, but somehow it could be a smell, it could be a movement, it could be speed, it could be a tone of voice, it could be being yelled at, but that trigger triggers the brain back into thinking that it's in danger again, and then that person reacts and goes into fight flight. They may fight, they may run, they may scream and holler, they may freeze. It just depends. Generally, I'll go into a panic attack as well. So let's go back to that 6-year-old or 10-year-old that's traumatized, whatever type of trauma it is, they're all horrible. The hippocampus is now no longer going to develop. So that hippocampus at 20 is basically a 6-year-old, still at the 6-year mark, and doesn't seem to continue its development through that early 25 years without resolution of that trauma. And so the person is a 25-year-old, let's say, but their amygdala and hippocampus are still locked down in a fight-flight mode, and the processing is different than a person that doesn't have PTSD, and they are hyperreactive and hypervigilant, and again, they have not developed in that area of the brain past that 6 years old. So I use the term squirrel brain. So a person is triggered, the trigger comes in, whether through sight, sound, or any of the senses, and goes straight to, for all of us, goes straight to our amygdala and hippocampus region of our brain where our fight-flight region is. Memory is also a large part of the hippocampus's responsibility. So oftentimes people with PTSD have bad memory. But the trigger comes in, and let's say it's a thunderclap, and so the person hears that boom, goes to the hippocampus, goes to the amygdala, and then it should come back out to the frontal lobe, which is where executive functioning is, but doesn't. The brain reacts. The brain reacts like, that must be an explosion. If that noise is a trigger for that person, and because their trauma is related to something that was loud, a gunshot or bombs or a car accident, etc. It could take 20 minutes, it could take a couple hours before the brain finally works its processing back up to the frontal lobe, says, okay, I'm safe, and the panic attack subsides, the anxiety, maybe the crying, that fight-flight response, whatever it is slowly subsiding as the brain works its way out of the quick response and up to the frontal lobe and our executive functioning. For a person who doesn't have PTSD, that thunderclap is heard. There's might be a little bit of reaction, but the brain goes right into the executive functioning back in the frontal lobe and decides if it's safe or not. And in that split second, with thunder and lightning, especially if there's a storm outside, most of us can be startled perhaps, but not go into a hyperreactive state. And that's the symptomology of PTSD is that, of course, you're in a hyperreactive state and a hypervigilant state. And so the squirrel brain is what makes it difficult to function if there's lots of triggers. And so we look at it from the outside, or people, a family member, a loved one, doesn't understand why you're reacting that way because it doesn't make sense to the situation. I just walked in the door and you started screaming and hollering at me, or you started crying, or you started having a panic attack, or you started fighting me, depending on whatever the situation is. So we're like, why are you behaving like this? Once the person calms down, unless you choose to engage with that person and fight with them, once they calm down, you can try to have that conversation. What we usually see and hear from our clientele is the constant level of invalidation. So it wasn't that big of a deal. It's been a long time. You should get over it. You're crazy. This is, if it were me, it wouldn't be a big deal. Pull up your bootstraps and get going. Stop letting this affect you. You should be over it by now. All those things that we've heard before, because we don't see anything wrong with that person until they're reactive. So it doesn't really make sense. If they're bleeding out, we'd rush them to the hospital. But with PTSD, there's nothing to see. We just see the person and they seem normal until they get triggered. And so if it happens over and over again, it's kind of like, enough, you should be able to stop this on your own. It's just not the way it works. It becomes almost a physiological issue, and that person has to resolve the trauma. If they don't resolve the trauma, what I see is progressively gets worse and worse. My average female that comes into the office, if not brought by a parent or a loved one, is about 43. They've been traumatized, oftentimes sexually at a young age, somewhere between birth and 16 years old. Of course, it happens later than that as well, but the average is that. And then there's continued trauma afterwards. There seems to be bad choices, and I don't know that's bad choices in other relationships. It seems to be that's who they attract, and it doesn't ever seem to work out. So the traumas get continued. It becomes like a onion with layers and layers and layers of trauma. Lots of relationship issues with family and with loved ones. It's a constant battle. Oftentimes they've done tons and tons of therapy. They've tried medications. They may be on medications. A benzo, a Xanax, Klonopin, clonazepam. Those are the big ones that have been prescribed mostly for trauma in the past. The doctors are slowing down now on prescribing so much of the benzos because they are highly addictive. I see a lot of people smoking a lot of marijuana daily, oftentimes throughout the day. Of course, alcohol is another one. Veterans often are drinking alcohol or smoking marijuana or both. It's usually a depressant to slow down that feeling of being anxious all the time, because once we're in that fight-flight, we're in a constant state of anxiety and hypervigilance and hyperreactivity. So there's lots of adrenaline, cortisol, epinephrine surging through our bodies, which cause somatic reactions as well, which we'll get into. But that's the reason that person always feels on edge. So let's talk about the symptoms. So hyperreactivity, hypervigilance. Let me touch on those a little bit. The hyperreactivity, as I alluded to before, is we're all reactive to that thunderclap to some degree, but some people will be hyperreactive and they'll react with such distress that you're like, the person almost got shot. Hypervigilance is that constant awareness of around you. Like you might want to sit in a corner in a restaurant so that you can see everything out in front of you. But generally, it's not to that level. Most people that are hypervigilant are just aware. They hear sounds. They see things moving more so. Kind of like a squirrel, they're aware of everything, because the danger for a squirrel is from above, from below, and horizontally. So they are constantly watching out for what's around them that's going to hurt them. And that's how generally somebody with especially severe PTSD is going to be hypervigilant. We see major sleep disorders. Most people that have PTSD don't sleep well at all. They may sleep or appear to sleep, but they're not getting good sleep. They're restless. They're waking 3, 4, 5, 10 times a night, or they're not getting any sleep. They're sleeping 2, 3, 4 hours, broken throughout the night, oftentimes because of nightmares. There's generally very vivid, unpleasant dreams or nightmares, maybe even of the specific traumas. But those things are continual, and as I said before, as time goes on, the symptoms seem to get worse and worse because we get more and more tired. We're getting exhausted, we're getting worn out. We have to sleep to heal. And sleeping 8 hours a night isn't going to heal PTSD, but it heals our physical self, so we have enough strength to continue that inward battle. And nightmares, of course, are alarming at best, and they wake us up, and they are very concerning, and then tough to go back to sleep. So those are big ones. Suicidal ideation is usually a part of it. They may not discuss that, but if you're constantly in that state, you're not getting sleep, there's thoughts of, what if I wasn't here? If I got hit by a bus, it would be okay, or possibly even getting to the level, which many people do, of actually attempting to take their lives, which of course is very sad. It depends upon that individual and the things that are ongoing. Flashbacks. Generally, people have flashbacks, and a flashback can be as clear as, on a daily basis, I see what happened on that battlefield, or I see what happened in that car accident, or I see how my father treated me when I was a child, or my boyfriend, or my girlfriend, or my wife, or my husband. Whatever the situation is, you can actually go back, not voluntarily, it just sort of happens, something triggers you perhaps, and you go back into a flashback, so you're flashing back to the actual incident. And of course, that can be re-traumatizing because you're back in it. And nightmares are along those lines as well. Panic attacks are a big one. And having a panic attack is the top piece of the anxiety. You're always in an anxious state. The anxiety builds. Could be with a trigger, could just be with life. Life can be triggering because things can be difficult. You get fired from work, or your relationship's falling apart, or it could be anything that triggers you, or it could just be an accumulation. And the panic attack, sometimes people have them 2, 3 times a day, sometimes it's once a week, sometimes it's once a month, but a panic attack is that huge anxiety reaction to where you start shaking, where your heart starts pounding, you can feel your blood pressure, you start to sweat perhaps, and you almost feel like you're going to pass out, and it's scary, and sometimes people will pass out. I've heard stories of somebody just passing out in Publix and in a grocery store, and of course people think they had a heart attack and they call 911, and then the person comes back too and says, no, I'm fine, I'm just having a panic attack. And of course the EMT will figure that out pretty quickly once they get that history, but that happens quite often. Substance abuse becomes symptomology. It's not necessary, of course, but it seems like it's pretty prevalent, and I already mentioned the substances that are most likely to be used. But there's also the somatic reactions. So having trauma, for being traumatized and enduring the trauma, the PTSD for years and years, we start to see physical somatic reactions: losing hair, welts, rashes, pain, I think cancers, the inability to eat. Almost everybody that has PTSD has severe GI issues, meaning that their gut is not doing well, whether it's nausea. Many people with PTSD have nausea, especially in the morning. They wake up and feel nauseous, but it can be at any time. They have diarrhea or constipation, stomach pain, they can't eat certain foods. That's because of all the adrenaline that they're processing all the time, all day long. So the adrenaline goes straight to the gut after it runs through the body, and it tears up the stomach. And so that's a big somatic reaction, and pretty standard. I've seen people with pain in different areas, or eyesight changing. Memory, of course, is a piece of it. Memory seems to be weak. Processing, doing simple math gets harder. Cognitive does degenerate to some degree. But all kinds of somatic things come from trauma that we do see. So the way we work with somebody who's been traumatized, there's a couple ways that trauma can be resolved. And historically, it was systematic desensitization, and that's what we would see in the VA hospitals back when the shell shock started, which was from World War I. So what we see with systematic desensitization is it's a therapist, psychologist, psychiatrist is asking the person to relive the incident. If it's a specific trauma, in this case, veterans are coming back from World War I, they've got this PTSD, which they were calling something else back then, and they tell me what happened in that foxhole, and they go through the whole story. They say, okay, now tell me again, and you do it over and over and over again, hoping to desensitize the brain to the actual shock of that incident. Mild success, some success, but it also can re-traumatize that person in the brain because they're bringing up what happened that was so horrific. Another one is hypnosis, clinical hypnosis. The problem with hypnosis off the bat is half the population won't do it. Clinical hypnosis can be extremely helpful for specific traumas. So in this case with a veteran, if it was they didn't have PTSD before they went into the military and something happened on April 3rd, if they are hypnotizable, which most people are, that clinical hypnotist will take them back into that time frame under hypnosis in a hypnagogic state and process through that time frame, through that incident, while the person is hypnotized. They're still conscious, they're listening, but they're in a subconscious state, so to speak, so it's not traumatizing. We are looking for an abreaction to resolve the trauma, so they may go through it several times. The person isn't talking, they're just lying there with their eyes closed, and it can be very effective. In fact, there was a doctor, a psychiatrist that was in the hospital in Daytona Beach. I believe it was after World War I. It could have been II, but it was for shell shock and veterans, and had great success with clinical hypnosis in that hospital in Daytona Beach. There's a number of research studies on that. Most people, though, lean towards medications. It's easier, it's faster. It does, so does alcohol or a Xanax or marijuana calms that brain for that temporary piece of time. It's just that there's lots of side effects. So as medications came online in the late 59 was the first antidepressant, but 60s and 70s and 80s when we started getting stronger medications that actually would affect that, most people would just lean to that. Nowadays, it seems like in the last 10 years, most people are not wanting to do medications. Though a lot of people do lean on marijuana, but they're they're doing less and less of the benzodiazepines. And again, I think the doctors are prescribing less as well. Now, those are helpful, especially during a panic attack, but it doesn't resolve trauma. It just manages it. We call it a Band-Aid. It's helpful to stabilize that person, but it doesn't resolve it, so they still continue on with the side effects. So clinical hypnosis, systematic desensitization, no. Therapy can be helpful, but in therapy I do not like to discuss. I don't want to discuss the trauma because it's bringing it up, and we're not going to resolve it that way. So we love neurofeedback because we don't have to talk about it. I don't need to know what happened, when it happened, or why it happened. I just need to know that there's trauma, and this is, with the symptomology, we can see it's PTSD. And then with neurofeedback, it's a non-invasive modality that's actually quite pleasant to do. We're working with the brain at the cellular level without anything going into the brain. It's just listening. Basically, the way neurofeedback works is it's a very fast feedback loop. So we're collecting how the brain fires through an EEG. You see the brain waves on the computer, and the computer gives back to the brain feedback in the form of sounds, movements, fractal images, all in less than a third of a second. So then it becomes a continuous loop of feedback. The brain recognizes itself and starts to self-regulate. The brain has the ability to resolve these traumas. Why it doesn't do it itself, we haven't figured out yet. But with neurofeedback, it's kind of like looking in a mirror at itself, and is able to self-regulate just like we do when we look in the mirror. We look in the mirror and say, oh, I need to brush my hair, or put on makeup, or change my shirt, or whatever what the self-regulation is, or nothing. And this is the way it works with neurofeedback. The brain's able to see itself and self-regulate. It's fascinating. Science has been around since 1959, and we've been doing it for well over a decade, and probably have done about 40,000 sessions at this point. Very successful with trauma. And the big thing with neurofeedback and trauma that we love is it's not just getting that one trauma that happened at a certain date. It's unpacking all of those layers and layers and layers of onions, because once we're traumatized, no matter what age, the trauma continues. It continues to affect us, and it seems that most people have more traumas after that initial trauma. They seem to be more susceptible to being re-traumatized. So there may be 20 different traumatic events from birth to 30 or 20 or 40 or whatever age, 70, whatever age they come in at, and hypnosis you can't get to all those. And we'll talk about EMDR as well. The neurofeedback does get to, it's working in the brain. So then the research shows, actually a VA study that showed with functional MRI that the hippocampus actually comes back online after resolving trauma. In this case, it was with neurofeedback. So resolution of trauma with neurofeedback, hippocampus comes back online, and memory gets better. Reactions aren't as immature, and everything else the hippocampus does is now at the age you are, which is really cool. EMDR, eye movement desensitization, is a modality that's come online in the last 10, 15 years, more popular in the last 10, 15 years. It's been around a little bit longer. But the concept is almost to get you in a hypnagogic state by distracting with eye movement. So they may have a finger or something else that's moving to you're watching with your eyes while you're telling the story of what happened. So the systematic desensitization piece with here's what happened, here's what, telling the whole story, yet being distracted with some sort of eye movement, whether it's a light or fingers or whatever that particular practitioner is using. It's great for shallow traumas. I don't see it getting into the onion peels. It's, if you had a car accident 6 months ago, I call them shallow traumas. It happened recently. 6 months ago, you're a car accident, you can't get back in a car. It can be very helpful. EMDR seems to be very helpful with that because it's not re-traumatized. It's hard to tell the story of what happened in the car, especially if it was horrific, but it's not as hard because it's still fresh. And you may know, I mean, if you're 30 years old and something happened, if you're even aware of it at 6 years old, and some people aren't aware of what happened because they buried it so deep, it's very difficult to get to that and not have re-traumatizing of that incident if it's that far back and that deep in the psyche. So EMDR, clinical hypnosis, neurofeedback. Of the three, I've done clinical hypnosis for years. I did that as well. Have great success with physical pain and also PTSD with clinical hypnosis. It's just difficult, and it's very particular to the practitioner. And like I said, only about half the population would do it. But with neurofeedback, we're getting so much more than just a particular trauma. We're getting that stomach. We're getting the somatic reactions. We're getting the whole nervous system to calm down by utilizing that modality. So the person becomes much more functional, not only with just the resolution of trauma, but also the resolution of other things. What we see with nightmares is within 3 days, 3 nights, they're not having nightmares anymore, generally. Also, they start sleeping within 3, 4, 5 nights. Also, generally, some people, depending upon the medication use, might be a little slower, but generally within 3 to 5 sessions, we see people sleeping well, and also not having nightmares. And they go to unpleasant dreams. They might be more vivid dreams if they're sleeping deeply, and where the goal is to get them to 8 hours with uninterrupted sleep, and that does happen almost all the time. Also, along with this, sleep, we see suicidal ideation go away usually within 3-4 sessions. And that's really important, because when somebody has suicidal ideation, especially if it's really prominent, that's top of mind. So what happens is, I call it the hope light. The brain turns on the hope light when they start to feel better, when they start to feel those pressures receding, when they start to realize that it's not them, they're not crazy, it's actually their brain has just been assaulted, almost like a traumatic brain injury, and is holding on to this trauma. It's not their fault. Invalidation is really not helpful. It's also almost re-traumatizing. So when somebody says, yeah, get over it, it's no big deal, happened a long time ago, that's really invalidating and destabilizing to that individual, because now they're not sure, should I have gotten over it? Should I be doing something different? What's wrong with me? How do I get out of this? And of course, then they internalize and feel bad because you're telling them they're not worthy, and that's just not the case. And so if you're in a relationship with somebody that has PTSD, don't invalidate, support, say we need to get help, because it is going to get worse. Internet, social media is a big issue, especially for kids. The bullying is now not just in front. When I was a kid, if there was bullying going on, it happened while you're at school. You might be afraid to go to the school for a little bit, but usually it waned. With the internet, it's there all the time, and people are grouping up. It's really bad. Internet, social media for children is really dangerous. It's changing the course of how children grow up. Also marijuana. The marijuana is very easily accessed, especially if the parents have it, and kids start 12, 13, 14 are smoking as young as, I see 9, 10, I'm sure younger. But when they're smoking in that young age, 12, 13, 14, we see a lot of physical distress. We see a lot of nausea, the lack of diet, headaches, inability to sleep, waking up in the middle of the night again with nausea. And they don't relate it to the marijuana, they just think they're sick. But the emergency room doctors are reporting that they're seeing it more and more and more over the last few years. The marijuana is too strong. It's not the Maui Wowie of the 60s and 70s. It's a medicine now, and it's extremely powerful. And those children's brain cannot handle it. They should not be smoking marijuana or any of the side pieces, the Delta 9s, etc., at any level. Again, all these medications, if you're an adult, whether legal or not legal, are helpful in the moment. They don't resolve the trauma, and the trauma needs to be resolved. So that's kind of a great rundown of PTSD, post-traumatic stress disorder. It comes from all sources, like I said, sexual abuse, physical abuse, emotional abuse, accidents, wartime, and it's, as it says, it's extremely traumatic. I hope that's helpful. I'm sure I'll field some questions for that, and if I missed anything, I certainly would love to talk about it. You have a great week, and if you do have post-traumatic stress disorder or a loved one has PTSD, please reach out to somebody in your area to get help. Preferably look for somebody who specializes in trauma, utilizing neurofeedback. Therapy is great, do therapy. I don't suggest systematic desensitization. EMDR is non-invasive, so if it's close and local, it's certainly worth trying. If it helps, and it should help, it may not get all of it, but if it helps, then awesome. But to get everything, I would really look into neurofeedback in your area. And we look forward to seeing you on our next podcast. Next Thursday, we will have another podcast for you. And until then, have a great week. And signing off, this is the Bipolar Guy. Thank you.